We're terribly behind schedule, but that's okay. We want to make sure we get all the information in that is necessary. Any questions from anything we covered last time? No, fantastic. Let's continue on. So we're talking about, we went over cough stuff. I just heard a cough, so it's very apropos. Getting into some of the infectious, yes ma'am.
Sorry, I just have a question. So for dexamethasone and prednisone, the only difference is that that prednisone is less potent?
Yes, that is true. The half-lives are a little different too. So for instance, and we'll talk about asthma a little bit later on, but say for instance you have someone who needs like a 5-day course of prednisone. They basically take it once or twice daily for 5 days, versus like dexamethasone, you can actually give 2 doses like 36 hours apart and you end up getting the same sort of coverage there. So there's other differences, but that's kind of the main thing there. All right. Anyway, so moving forward, so talking about some infectious issues with the lungs. So certainly coming up with bronchitis is going to be a pretty common complaint coming into urgent cares, emergency departments, all things like that. However, most of the time it's going to be what sort of etiology? Well, viral a lot of times, right? And so again, this is another reason why people frequently get overprescribed antibiotics. You're not always going to be doing cultures in these patients. It's probably very rare that you would be doing that unless you had a good indication to do so. However, here with bronchitis specifically, it's that inflammation of the bronchioles not really getting, or I'm sorry, just of the bronchi, not really getting any deeper than that. We'll talk about pneumonia a little bit more specifically in a few minutes here. Obviously, people who are at risk for this, intend to include people who have sort of impaired lung function. Those chronic smokers, COPDers are going to be the ones you see that a little bit more frequently in. And so as I mentioned, very frequently it's viral, due to influenza, adenovirus, things like that. Is there anything we can really do for that in terms of antiviral therapy? Not really. If it's influenza, certainly we could treat that, right? So we'll mention Tamiflu. Did I mention that in the ENT section? Yeah, we talked a little bit, yeah. So Tamiflu is a good option. Remember, this is going to be flu season kicking up here. Did everyone get their flu shot yet? I have to get mine still, so I'm delinquent. But point being is that definitely would recommend that, because you want to make sure you're protecting yourself, not even if you say, well, I'm not going to get the flu, but you don't want to pass it around to other patients too, right? So something to consider. But for most of the other viruses, we don't really have anything we can do with them, right? So when it is bacterial, this is where you're going to see common upper respiratory bugs we kind of already talked about in the ENT section. Things like your strep pneumo, your H. influenza, things like that. But now we're going to start to see more atypical bugs, right? So we're going to start to see more things like chlamydia, mycoplasma, things like that, maybe even like a Legionella, right? Classic Legionnaire's disease. This is where you're going to start to see more of those start to pop up as you get down deeper into the respiratory tract. And frequently it's going to be sort of a secondary infection. So they'll have an initial viral infection that kind of predisposes them, kind of plums the pump, so to speak, so that they're more likely to get a bacterial infection on top of that, right? In general, it's mostly supportive care, right? So again, if they have a fever, what are you going to give them? Tylenol, what else? Ibuprofen, right? So your antipyretics you can administer there, right? Antitussives, what do you have if they're coughing a lot? Dextromethorphan, right? Maybe if that was not working for them, or maybe they had some CNS side effects, what could you use instead? Tessalon pearls, like benzonatate, right? So there's some options that are there. If that doesn't work, you can always use opioids, but that's, again, something you don't want to have to use if you don't need to, right? Obviously fluids, because they can get dehydrated. You want to make sure they're staying well hydrated from that standpoint. We don't oftentimes recommend using antihistamines, because that does tend to dry things out, and so it can make it more difficult to cough up all that kind of junk in the lungs, and so that's where all the bacteria are living, so you want to get rid of that if you can, right? So it can actually prolong symptoms and make it more difficult. It makes that those mucus secretions kind of more thick and more viscous, and so harder to clear. So typically antibiotics are not recommended. However, if they do have symptoms for say greater than 5 days, that's when you want to start to consider more bacterial involvement, right? So some things that we can administer to these patients. Because we do think about things like atypical bugs, this is where you want drugs that cover atypicals, right? So what are some options there that will cover atypicals? So tetracyclines, macrolides, what else? Potentially fluoroquinolones, right? But again, we want to think about what's our resistance patterns. We want to think about side effects that could be occurring here. So again, you have to take it all take it on a case-by-case basis. So for instance, like out of these three here, doxycycline, macrolides, and say a fluoroquinolone, which one would be sort of relatively contraindicated in like a pregnant patient with bronchitis? Yeah, doxycycline, right? Why is that? Depressed skeletal growth in the fetus, right? So we don't want to do that, right? For the macrolides, what would you worry about? Case QT prolongation, right? So maybe not good for someone with a congenital prolonged QT, right? If they have that history. It may not be good if they have what kind of drug interactions? Yeah, if they were taking other medications that are metabolized by CYP3A4, that could be a concern, right? Fluoroquinolones, who would you maybe avoid that in? Why kids? Tendinitis, about tendon ruptures. It's rare, but you see it more frequently in children. So again, not to say we never use fluoroquinolones in kids, but it does happen occasionally. Typically, we avoid using our fluoroquinolones mainly due to the fact that we're seeing more and more resistance to strep pneumo, which is why we're kind of saving that as sort of a backup agent, or using it for more like specialized cases here. But again, any of the tetracyclines are going to be fine. They're cheap. They're easy to use. Can't cause some photosensitivity, so hopefully they'll stay inside because they're sick anyway. So that can be avoided there. Now moving into pneumonia. This is going to be obviously a much more kind of involved sort of infection here down into the bronchioles and the alveoli. And again, who's at risk for developing pneumonias? Immunocompromised individuals, sure. Who else? Elderly patients, right? Why elderly patients? So they may have some relative immunocompromisation, but also like as you get elderly patients, especially with like some depressed mental status issues, they can have these micro aspirations that can occur. They don't protect their airway as well, so that can be a source for infection potentially. Certainly very young kids potentially, because again they have an underdeveloped immune system. What about any particular social habits? Yeah, you worry about smoking too, right? Anything that's impairing sort of those ciliated cells that kind of normally brush up stuff from the bottom of the lungs all the way up to that way you can expectorate it. Normally, that should be keeping the lungs fairly sterile, right? But if you interrupt that, that's when you're going to run into problems here, right? And so, again, we can see microbes coming in from aspiration. You can see it from just inhalation of infectious aerosols. Sometimes we'll have patients that will start off with more of a hematogenous spread. So say they start off with a UTI that got into the bloodstream, and then that spreads into the lungs potentially. That can happen there. Or you could just have like a direct inoculation, so some traumatic event maybe have directly put in the bacteria to the lungs. It just depends on the situation. So looking at CAP, when I say CAP, what does that mean? A community-acquired pneumonia, meaning they're getting it from where? Out and about, right? So again, they don't have any exposure to a healthcare environment. When I say healthcare environment, what does that mean? Hospitals, obviously. What else? Nursing homes, dialysis centers, infusion centers, anywhere that people are, constantly getting medical care. Those are places where you're more likely to see a healthcare acquired sort of pneumonias, right? So anyway, so looking at CAP, just our community acquired pneumonia, and who do you think tends to be sicker, hospital acquired or community acquired pneumonias? Why hospital acquired? More resistant bugs. These patients may already be sick in the first place because they're in this healthcare environment. So yeah, certainly those tend to be the sicker of the patients. So when you find patients coming in with CAP, you don't frequently have to do cultures on all those patients, because most of the time they do pretty well with empiric antibiotics, and you don't always have to do diagnostic tests just to perform that, right? If they are coming in-house, if they are sicker, that's when you want to consider doing things like blood and sputum cultures. That's where you want to think about things like that. Now, again, we do this prior to antibiotics, and why is that? It can affect your sample, right? So if they have antibiotics on board, that can affect your ability to actually culture out those samples there, right? And why do you think you do a blood and a sputum culture? Yeah, you want to make sure it wasn't a hematogenous spread, right? You want to make sure that that is not going to be another source for infection you may want to consider as well when you're treating that. And again, sputum can be a problem. Why? Like contamination, right? So if you end up getting a sputum culture and you see a lot of epithelial cells in there, you just assume it's like spit, right? And you have all kinds of stuff in your mouth that may not be pathogenic, right? So again, obviously the gold standard would be like get a bronchial alveolar lavage, but that's much more labor intensive. It's not something you would do in a routine community-acquired pneumonia patient. But anyway, so by getting that sputum culture and getting the gram stain there, it's somewhat controversial, but as I mentioned, it's contaminated, and you may not always get that actual pathogen there, especially if it's like an anaerobic bug. It's not going to culture out on typical aerobic sort of cultures, right? So anyway, there's lots of reasons or ways to determine how you're going to treat these patients and where you're going to treat them at. I'm not going to get into the disposition here, but this is where things like CURB-65 and pneumonia severity indexes can tell you, hey, how sick is this patient based off of vital signs, based off of different laboratory features like white count and things like that. They'll determine, where do they need to go? Do they need just to go to a normal med surg floor? Do they need to go to the ICU? Things like that, which I'm not going to get super in depth on. I just want to focus more on the treatment here. Looking at the etiology here in terms of the bugs that are most likely to be present. Again, on the outpatient side, you're less likely to see resistant bugs, but it still can happen here. This is where we see things like our strep pneumo. You see atypical bugs like mycoplasma, H. flu, Marksella catarrhalis. Again, a lot of the same upper respiratory bugs we saw when we were talking about ENT stuff, right? Just with the addition of now these atypical bugs. So your treatment does have to tailor that a little bit to consider those atypical bugs. Notice here for inpatient patients who are sick enough to need to be inpatient, but maybe not in the ICU, it's not in the highest level of care here. This is where you can see more things like, Legionella, maybe it was an aspiration, so you're broadening out your likely bugs here a little bit. And again, treatment may need to change to reflect that. And then if they're the sickest of the sick, they're going to the ICU. This is where we start to worry about things like Staph aureus. And we got to start thinking about things like gram-negative bacilli, like maybe there's like E. coli or Klebsiella, or there's a Pseudomonas. And again, your coverage is going to have to broaden out. So based on how sick they are, we may need to use much more broad empiric therapy, including coverage for things like MRSA potentially, Pseudomonas, and so it's good to remember what drugs cover that stuff. So if you needed to treat something for MRSA, what would you go with? Vanco, right? So again, if you're thinking gram-positive killers for inpatients, just go Vanco until proven otherwise, right, for the most part. I got one student who's always like, Vanco's the answer for everything. Doesn't matter what kind of infectious disease question I ask, he's like, Vanco. I said, we're talking about viruses here. And he's like, I don't care, Vanco anyway. Just rule it out. But sometimes you'll be right. Broken clock is right twice a day, as they say, right? So what are some reasons why patients may be more at risk for developing, say, like a resistant strep pneumo? Well, the older patients obviously are going to be more at risk here if they've had a beta-lactam within the past 3 months, right? So why do you think that will lead them to be more likely to have resistant strep pneumo? Because when you have antibiotics on board, you're disrupting the normal flora, you're putting selective pressure on the strep pneumo that's there, so that way you're going to be weeding out the more resistant bugs, and then now they have a nice platform to replicate on, right? So again, this is why that you're going to see that previous antibiotic use may tailor you to decide what type of antibiotics you're going to use for this other patient, right? So again, always ask about, well, what antibiotics have you received recently, okay? Alcoholism, immunosuppressed patients, these are all going to be more at risk here. And then any kind of medical morbidities that kind of induce some degree of limited immunocompromisations like diabetes, they have renal insufficiency, cancers, anything like that. And then what do you think exposure to kids in daycare? So like daycare is like this little like cesspool of bacteria, and like everyone's getting each other sick, and then they're on antibiotics, and they breed more resistant bugs, and they give it to their friends, and they give it to 2 friends, and so on and so on. And so again, that's why if you have that exposure, so if you have like grandma who's taking kid to daycare every day, like that may predispose them to more resistant strep pneumo than you would see for someone who did not have that exposure, right? So again, things to think about in terms of your history. So enteric gram-negatives, right? So we're thinking things like Klebsiella, Proteus, E. coli, people who are residing in a nursing home, people who have maybe underlying cardiopulmonary disease, recent antibiotic therapy, that's going to increase their risk, right? And that will also kind of increase your risk getting down to especially Pseudomonas risk, right? And again, what do we say about coverage for Pseudomonas? Anyone remember? That is the case we're actually going to have to double cover if you're really worried about that, because we do worry about resistance and because it can be so dangerous in those infections. So if they have like a structural lung disease, COPD, if they have corticosteroid use, why do you think that predisposes them to Pseudomonas? Immunosuppression, right? Corticosteroids cause immunosuppression. Broad spectrum antibiotic use within the past, say, 7 days or so to a month. And then malnutrition is also another thing, because again, if you don't have good nutrition, you can't really support a good healthy immune system, okay? So for outpatient treatment, if you have a patient who doesn't really have any risk, like we mentioned, of strep pneumo, first line, you're typically going to be thinking more of things you want to cover in terms of your atypicals, right? So things like azithromycin, clarithromycin, that'll be good for covering those atypical bugs, along with non-resistant strep pneumo. You get some of those H. flus and things like that. For most patients, that's going to be fine. As a second line, though, doxycycline, minocycline could be a decent alternative for those patients there. Okay, azithro tends to just be better tolerated than the tetracycline, so that's why we end up going with that one first line. So if they do have risk factors, though, this is where it gets a little more complicated, because now you're going to need something that will provide coverage for both that resistant strep pneumo and the atypical bugs. So you might use something like amoxicillin plus or minus clavulanic acid, depending on your patterns. And how would you tell in your particular area where you practice what the resistance patterns are like? Remember those antibiograms we talked about? That can be really helpful, right? So you can look to see, well, the strep pneumo, how many times have we cultured out strep pneumo and it's been resistant to amoxicillin by itself? If it's pretty high, if you only have maybe like a 75% susceptibility rate, maybe you just go ahead and go with Augmentin instead, right? So bump it up and include that beta-lactamase inhibitor. Or you could use something like a 2nd or 3rd generation cephalosporin. So one of those plus a macrolide, okay? So So again, by combining those two, you get that atypical coverage, because do penicillins normally cover atypical bugs? No, they don't, right? So by using amoxicillin or using something like second or third generation cephalosporin, you get that additional coverage, okay? Or you could use something like a respiratory fluoroquinolone by itself. And so when I say that, it's mainly talking about things like levofloxacin and moxifloxacin are the two big ones. So maybe if you had a patient who really couldn't tolerate any beta-lactams, right, even if they couldn't tolerate cephalosporins, you may want to use these as a backup here. Again, realize though that look at your antibiograms, look to see what the resistance pattern is to levofloxacin or moxi based on your area where you're practicing, okay? So you can either use the combination here or just use levoquin by itself, right? Because again, fluoroquinolones are going to be able to cover the atypicals and that strep pneumo and all those other bugs we talked about. So for inpatient treatment, so do you think you're going to go with oral therapy, IV therapy? Yeah, if they're sick enough to require to come in-house, they're probably going to require IV therapy for the most part. Obviously, putting them on an IV also gets them at risk for what? Infection too, right? So again, the goal is always to get them stabilized on IV therapy and eventually switch them over to PO. And that's a really big role that you can help to play there to get them off of their IVs. If they're taking good PO intake, if they're able to tolerate oral medication, switch them over, right? The white count's coming down, fever's coming down, they look good, switch them over to PO, and that can help to get them out a little bit faster there, right? For non-ICU patients here, you can utilize an intravenous beta-lactam. So this includes like ceftriaxone's a really common, popular one, because how often do you have to dose that? Just one time daily, right? So you just do ceftriaxone 1 gram Q24, easy peasy, right? You don't have to even think twice about it. Because do I have to worry about renal function with Rocephin? Nah. Do I have to worry about that with other beta-lactams? 100% you do, right? So if you have an older patient who's coming in, they have bad kidney function, like ceftriaxone tends to be a very good option to go with there, okay? So you do that plus an intravenous or oral macrolide. And I will tell you that for the most part, IV macrolides are not super popular. We do tend to go oral in most of those cases there. And the bioavailability is good enough that's not really going to be an issue. So you could do that, or you could do something like a doxycycline or maybe a respiratory fluoroquinolone, okay? And again, really reserve those for patients with allergy just due to the fact that you're worried about the side effects, you're worried about interactions, all those other things there, okay? Now, if they're in the ICU, certainly we just want to start all IV therapy, and then you have to consider if it's MRSA, right? We are starting to see more community-acquired pneumonias that do have MRSA present, and so you have to keep that on your differential as well, okay? In that case, what would you cover it with? Vanco's your go-to, right? And then you just say Vanco 1 gram, pharmacy to dose, right? No, you're going to be good PAs, and you're going to say, like, well, I'm going to ask for the advice of the pharmacist, but I'm going to make sure I can do this by myself if I need to, because you never know when that pharmacist is going to be on vacation. You never know when you're working somewhere they don't have pharmacy services. You want to be able to do that yourself, right? You're like, nope, I'm going to find that pharmacist. I'm going to be their friend. I'm going to make sure they dose all my meds for me. No. Anyway, so as I mentioned, who you might suspect community-acquired MRSA in are going to be patients who maybe have like a cavitary infiltrate without a risk for aspiration. That tends to be one of those findings you'll see on chest x-ray that can kind of clue you in on that. Or if they have recent influenza, that tends to make them more predisposed to getting a MRSA kind of super infection on top of that. And especially if you get your gram stain back and there's a lot of gram-positive cocci and clusters, that could be a really big sign there. And then if you couldn't give vancomycin to a patient, a good alternative is always going to be what? Lennys Lid is going to be a good option there, right? Now it's more expensive. You're going to have to get usually get approval to use that drug instead of Vanco, because again, Vanco is just our good workhorse. We just go with that 99 times out of 100, I'd say. Which agent that is good for MRSA could we not use in the lungs? You remember? Yeah, daptomycin. Remember that drug is one that actually gets inactivated with the surfactant of the lungs. That's kind of one of those unique things about that drug. It's good for like cellulitis or bacteremia. Definitely not good for pneumonias. Okay. For nosocomial pneumonia, which means what? Yeah, we gave it to them essentially, right? They got it from the healthcare arena there. Typically, this is going to be infections of the lung not present at the time of admission. So they came in for something else, they had a broken bone, and now they have a pneumonia on top of that, right? That's going to be as hospital-acquired nosocomial sort of pneumonias there. And so you can kind of break it down into just regular hospital-acquired. There's ventilator-associated pneumonia, and why do you think we break that out? Well, maybe not necessarily different bugs per se, but is it easier to get a pneumonia when you're on a ventilator versus not? Why is that? You have a big plastic tube going down into your respiratory tract. So even though you try to do things like have good oral care, use things like chlorhexidine swabs to try to keep the mouth clean, you still have this patient who is having this big plastic tube. What do you call that when you have like something that the bacteria can kind of grow on? for like a fomite, right? So it's kind of serving like that, right? So it's a place for the bacteria to grow on, get in down to the respiratory tract, and then cause infection there. So again, that's a really big concern anytime we have a patient who's ventilated for long periods of time, is we worry about them developing a ventilator-associated pneumonia, and these tend to be much more difficult to treat because again, you can't just rip out the ET tube if they're not ready for it because they still got to breathe, right? So that can be tough. And again, you're going to find this is the second most common infection in hospitalized patients after UTIs. And what do you think UTIs are common in that group? Yeah, because they usually have like a catheter in place, a Foley catheter. Again, another easy way for bacteria to get into a relatively protected site otherwise. And so you see it higher in the elderly patients, you see more in mechanically ventilated patients, and it's just a ton of mortality and hospital costs because if they get a ventilator-associated pneumonia or something while they're in-house and they came in for something totally unrelated, does Medicare want to pay for that? Not typically, right? There's like, well, why didn't you keep them from getting the infection? Why didn't you go under appropriate infection control protocols to prevent that from occurring, right?
So what's the healthcare associated pneumonia?
Yeah, so hospital acquired would be if you actually were in the hospital when it occurred. Healthcare associated means it was like if you go frequently to a dialysis center or if you reside in a nursing home or something like that, right? So we'll have a little bit more of a broader definition there. Because frequently you may get like a patient, we'd see this all the time in the ER, you'd have, grandma or grandpa get transported in from the nursing home via EMS because no one was watching them for a couple of days, they got dehydrated, and then they get this pneumonia on top of everything else. And so then they come in extremely sick, have to go to the ICU and go full, shotgun approach in terms of antibiotic coverage and just hit them with everything basically. And so that can be really, really tough. So anyway, as I mentioned, healthcare associated, those that meet the criteria here, so if they're in a nursing home, recent IV antibiotics, chemotherapy. Why do you think chemotherapy would be a risk here? Because it causes immunosuppression, right? So again, you're going to find that when we talk about oncology drugs, their main goal is to prevent the replication of rapidly dividing cancerous cells, but that also affects what other cells? All of our other normal cells that rapidly replicate. So like your hair cells, like your GI cells, like your white cells, right? So that's why they get immunocompromised there. Wound care, hemodialysis, all these patients can be at really big risk for developing a healthcare-associated pneumonia. Okay, so looking at risk factors, obviously there are certain things that are unmodifiable, like what? Can I change your age? I'm not going to lie about my age, but I can't change it officially, right? If they have a level of depressed consciousness, if they have large volume aspiration, these are things we can't really do anything about. However, things we can modify is if maybe we can get them off the ventilator earlier, potentially. If they have like an NG tube placed, maybe get rid of that potentially, because that could be another site for infection. Intracranial pressure monitor, so that's actually, again, a very easy access to a relatively protected site. And then what do you think H2 blockers or antacid therapies? We haven't talked about GI stuff yet, but these are things that reduce stomach acid secretion in the stomach. Why could that lead to pneumonia?
Inspiration.
Oh, so aspiration of what though?
Content of your stomach.
Well, there's no acid you're secreting in there, right? So there shouldn't be a whole lot of contents. Yeah, so think about it. Your stomach acid is normally at a pH of what? 2, right? So it's very, very acidic, very harsh for any bacteria to grow, and it's relatively sterile unless you have a H. pylori infection or something like that, right? So what happens is if you're giving them antacid therapy is that you're going to cause the bacteria to start to grow in the stomach, and then when they have these microaspirations, that's when you can end up seeing them develop a pneumonia from that. So there's that risk there. However, the other problem is when you have a chronically stressed patient who is in the ICU, they also end up causing, they're releasing a lot of cortisol, they're causing the actual protective barrier around the stomach to degrade, and that also leads them to develop ulcers because of that, peptic ulcers. So what do we give them in order to prevent those peptic ulcers? We have to give them antacid therapy, right, or an H2 blocker or something like that. So again, it's a double-edged sword of where we're trying to prevent one issue, but then it can lead to another issue. So that's where we have to do good infection control, make sure we're using things like chlorhexidine swabs, and make sure we're keeping the mouth sterile, things like that. So those are all things we consider being modifiable risks. So hopefully we can try to prevent if possible. So looking at nosocomial pneumonias, again, pretty broad spectrum in terms of the different bugs that could be causative here. So we have things like Pseudomonas aeruginosa, which is obviously the most common, and again, that should always be a big buzzword for you, Pseudomonas. You should think, okay, what are my drugs that cover Pseudomonas? Any ideas? Zosin's a good one. Piperacillin tazobactam. Cefapine's a great one. What else? Ceftaroline would be one. Then we don't use too often because it's still pretty new and try to hold it back if we can, but what else? Aminoglycosides, absolutely. What else? Monobactam, like what? We had one of those. That's Trianam, good. What else? What's another beta-lactam group? Carbapenems, right? Remember meropenem, imipenem, those are really good ones for pseudomonas, and then the fluoroquinolones too, right? So again, we have several different options that are available to us. It's important to remember what's in your armamentarium, so that way, if you can't use one, well, I got to use a backup agent, because you got to use two, as we'll see here in just a little bit. Anyway, other things you can see: E. coli, Klebsiella, Acinetobacter. Remember those gram-negative bacilli, they like to trade little vectors with one another, or little plasmids. They can actually like cause resistance to occur across species there. So again, resistant gram-negatives is a huge problem. Also from the gram-positive side, MRSA is going to be very common. So what do you use to cover all the gram-positives? Vanco. Vanco is going to be our best friend from that standpoint. And then also you have to consider, well, maybe like we're giving full bore antibiotics here, we're covering them with everything. However, they're not improving. The white count's still high, their fever's still up. You start to have to consider other possibilities, right? Could it be an anaerobic bug, right? Could it be something that is maybe fungal? Could it be something like a mycoplasma, like tuberculosis or something? You have to start to kind of consider all sort of comers at that point there. So again, Candida, Aspergillus, these are other things that could possibly be playing a role here as well. So again, you want to start therapy as soon as possible. Frequently, hospitals will have sort of timers to make sure that the patient's coming in with a nosocomial pneumonia, that you get antibiotics on as soon as it is recognized, because time is an important factor here. And anytime you're initiating broad spectrum antibiotics for these patients, you have to consider going full bore and trying to make sure you cover those multi-drug resistant pathogens, and you have to cover for MRSA and Pseudomonas. Once the cultures come back, then you can scale it down based on what's growing, right? So if it's just MSSA growing, what can I do? Dicloxacillin, oxacillin is a really good options there. If it comes back Pseudomonas, maybe I can take off the Vanco. Those are all things you can do potentially. But get your cultures beforehand, right? Otherwise, stuff may not grow very well. And again, looking here, so assuming you have healthcare acquired pneumonia, ventilator, or healthcare associated pneumonias here, considering if they have, say, a late onset, so say like greater than 5 days, or if they have risk factors for multi-drug resistant pathogens like colonization with something like Pseudomonas, say prior antibiotics or immunosuppressive disease, consider how you're going to be scaling out your antibiotics here. So we'll talk about either limited spectrum or more broad spectrum coverage of those MDRs. So when I say limited spectrum, basically what that means is that they have no risk factors, as mentioned on the previous slide, for multi-drug resistant pathogens. Cephalosporins are going to be a good option here, namely the third generation. So like Rocephin is great because, again, think about these patients that are really, really sick. They got this pneumonia. Maybe they have some bit of a bacteremia to go along with that. When they get really, really sick like that, their blood pressure usually does what? Goes up or goes down, you think? What do you call that when you get, like a bloodstream infection and they start to, yeah, right, so we talk about sepsis, right? We talk about SIRS and sepsis and all the good stuff, but basically you get hypotensive typically, right? And so that means that what gets underperfused? Places like the kidneys do, right? Because again, primarily you would like to keep your heart and your head alive. The kidneys can take somewhat of a back seat in those cases there. So because of that, you end up seeing that you can have kidney dysfunction as a result of this due to hypotension, and that means you have to worry about things like renal function. You have to go back and reassess that pretty much every day to make sure that you're not missing, a big drop in their renal function, right? Because you're monitoring serum creatinine. What else are you monitoring in terms of renal function? Urine output, right? And that's a very quick way to know how they're actually functioning there. If they go from, say, producing 1 ml per kilo per hour on day one, and then go down to, say, 0.3 mLs per kilo per hour, that's a pretty significant drop-off, and that's something you want to at least keep in mind when you're looking back and redosing your medications there. So Rocephin's nice because it doesn't matter what the renal function is, you just dose it the same way either way, right? 1 gram Q24, easy. But then you can consider as an alternative, though, maybe something like levofloxacin, moxifloxacin. Again, if you're worried more about atypical bugs in those patients there, then you would want to consider something like that. Ampicillin sulbactam could be a good option here, right? It's a beta-lactamase inhibitor in addition to aminopenicillin. If you're worried about, like, say for instance, an anaerobic infection, that's a good option to cover that with, right? Because remember, adding that beta-lactamase inhibitor does get additional anaerobic coverage. So that could be one thing to consider. Or potentially you could use something like ertapenem, which is a little bit more of a narrow spectrum sort of carbapenem there, okay? So those are your options in those cases. If you want to go more broad, this is where you're going to see this kind of full court press where we're going to be using a 3-drug regimen here. So basically, we're going to be using combination gram-negative therapy, which means we're going to be using an anti-pseudomonal cephalosporin. Primarily, it's going to be what? Mentioned earlier, cefepime is going to be the big one out of this group. An anti-pseudomonal carbapenem, Usually meropenem or imipenem are the most common ones. Doripenem would work as well. Or an antipseudomonal penicillin, which is going to be what? Zosyn, which is what? Piperacillin, tazobactam, right? Notice here you want to use something that's going to be working on the cell wall, and then you're going to be using something else that has a different mechanism there. That's why it's going to be using either a cephalosporin or a carbapenem or a penicillin. So that way you get some cell wall active agent, and then you're adding on plus something else. So either an aminoglycoside, or you're going to be using an antipseudomonal fluoroquinolone. Cipro can have plus or minus sort of coverage there on Pseudomonas, so typically levo is going to be the more common one you're going to go with in a lot of cases there, okay? So that, or the aminoglycosides, what options do we have with that? Tobramycin, gentamicin, amikacin is that one, right? And usually you'll find that aminoglycosides may be on a bit of a rotating schedule to try to prevent resistance. So whatever one's in vogue at the time, you just go with that one. Gentamicin, pretty common. Amikacin maybe, just depends on the season there, right? And then, so you have those two drugs, and then you're going to add on coverage for MRSA. And like I said, 95 times out of 100 is probably going to be vancomycin. Lennys Lid could be a decent backup there, okay? So again, I might have on a test, let's say, you know, patient coming in, you're worried about multi-drug resistant pathogens. Which one of these would be an appropriate regimen for coverage against, you know, the empiric, what would be appropriate empiric coverage? And I may have like, you know, Vanco plus Lennys Lid plus cefepime. And you would say, that's not right. Why would that be wrong? I don't need 2 gram positive drugs. I need 1 gram positive drug, right? Or I may have like daptomycin on there. You say no, because it's pneumonia, I don't want to do that. Or maybe I would put on something like, say for instance, you know, ampicillin sulbactam. And you'd say, no, why? Not, it doesn't cover Pseudomonas, good. So again, these are the things that we're bringing it back, right? So even though the bugs and drug section isn't on this test, you still need to know what your anti-pseudomonal coverage is. You need to know how to cover it. You need to know what's appropriate for these patients here, okay? So again, it all comes around full circle. We can't just throw away all that stuff we learned in the first test. It'd be nice if we could do that, but unfortunately, infectious disease is something we're always going to run into. So again, ceftazidime technically does have some coverage against Pseudomonas, but you end up losing this very quickly due to resistance, so this is not routinely recommended. We do this sparingly in some of our cystic fibrosis kids who are colonized with certain types of Pseudomonas. Pseudomonas does this thing where it can convert over from sort of like a normal Pseudomonas variety to what we call a mucoid variety, and it actually gets much more difficult to penetrate. It kind of has this like little protective barrier around it, and so in some cases we may require that. But for the most part, cefepime is going to be our go-to there. And again, it does require renal adjustments. You do have to watch out for that. In terms of anti-pseudomonal carbapenem, this is where you have imipenem, cilastatin. Cilastatin is actually just something that helps prevent renal toxicity with the drug there. However, what side effect do you have to remember with imipenem? The seizure history, right? So again, more often you're going to see if you don't adjust for renal function, but if you have a patient with a seizure history, it may not be the best drug to go to right off the bat, okay? And actually, I don't know if I've seen imipenem used clinically since I was like an intern back like in 2007 or something like that. So it's been some time. And again, every time I date myself, I'm just like, gosh, I'm getting old, right? Anywho, meropenem is going to be the one you're going to see much more commonly. So merum, fairly common in terms of carbapenem use. Now, actually, in a lot of places, you're going to find that they like to hold off on using those if ever possible. So we actually will have certain criteria. For instance, like maybe, you know, for instance, we require infectious disease to approve use of a drug prior to actually prescribing it. So, like for instance, if we have an order coming in, and again, this is mainly we're talking about adult patients, but say for instance we're over at Nemours, and if you as a PA working in the ER want to order meropenem for a patient, you're going to get an automatic little warning saying, hey, does ID approve this? Have you talked to an ID doc? And then we'll get the warning as well, and we'll call you up and be like, hey, did you get approval for this? And you'll be like, no. And I said, we can't have it. Pick something else, right? And I'll be a nice pharmacist and help you through and pick something along with you. However, it's going to be one of those things where you have to have certain thresholds in place to make sure that it's appropriate. Otherwise, you have rampant overuse of the antibiotics, and then when you really need it, it's going to be resistant and it's not going to work, right? So again, it's not to limit you guys' practice to say, hey, you can't do that, but it's to make sure we're using things appropriately, because antibiotics are so important that we have those stewardship programs to make sure we use them correctly, okay? Anyway, ertapenem is not great in this category here, mainly because it does not have great coverage against Pseudomonas. So again, if they don't have risk factors for multi-drug resistant bugs, ertapenem's fine. If you need to cover Pseudomonas, ertapenem is not a good option here, okay? And then piperacillin tazobactam is really the only one we're going to see here out of the anti-pseudomonal penicillins. Again, all of these require renal dose adjustment. In terms of your anti-pseudomonal fluoroquinolones, you're going to find that Cipro, levofloxacin are going to be your good options here. Note they also have good activity against the atypical. So if that is high on your differential based on history, you know, say for instance they were at a big conference and the AC unit was busted and everyone's got pneumonia now, right? It's like classic board question. I think it is. Legionella, right? You got to manage that, right? So Legionella will be covered with something like a fluoroquinolone, right? These are also nice because they have good lung tissue penetration. The lungs can be difficult to penetrate in some cases, which is why we'll talk about that with vancomycin in a bit there. But again, use it more judiciously because you can see resistance here. Also in older patients, like you're going to see altered mental status due to these medications here. You can see QT prolongation. You can see drug interactions, right? So fluoroquinolone should be used a little bit more judiciously in those cases, right? Were there any CYP interactions with any of our beta-lactam drugs? Actually didn't run into any of those, right? So again, this is why you have to be careful when you start to switch over to some of these other classes here. And we mentioned aminoglycosides. Now, if you recall, we do these drugs, we dose them such that we try to minimize the toxicity by giving just one-time daily doses. So we give a really big dose up front, and then we let that level just kind of drop off precipitously throughout the day. And even though you may get a level before the next dose is 0, is that appropriate? Yes, because remember we talked about time versus concentration-dependent killers. Aminoglycosides are what? Concentration. We want a really big dose up front, and then we get what kind of effect as those levels drop off? Post-antibiotic effect, right? So that's okay. That's totally great. The other big thing is they don't hold on to it as much in terms of renal function, right? So again, you have to adjust for renal function, but they're less likely to try to accumulate that drug because what organ toxicity do we worry about with aminoglycosides? Further renal toxicity and ototoxicity, right? You can damage the hair cells. Because guess what? Their patients are also going to be getting vancomycin, which can also do the same things if their levels are too high. So that's something you want to be concerned with. Now, if you recall, all of the beta-lactams we talked about were those time or concentration dependent. Those are all time dependent, right? So again, the dosing is going to be more frequent with those. So you may see something like, piperacillin tazobactam every 8 hours, every 6 hours, whereas this one's every 24. And that makes sense because you know how the drugs are working. You know why that's appropriate for the particular agents here. Okay. Again, also because they have poor lung penetration, by using a really big dose up front, you're going to be ensuring that you get higher concentrations in the lung tissue. Thus, you're more likely to actually kill off those bacteria. Okay. Now, vancomycin, this is another one that has remember we looked at the vancomycin structure. Was it pretty big or small? It was really big, right? This is going to be one that has a difficult time penetrating the lung tissue here. And so because of that, we actually shoot for higher trough levels. I'm not going to have you memorize the trough level specifically, but if I give you one on an exam and I say, here's the reference range, you should be able to at least interpret that, right? If it's too high, too low, etc. Remember, though, you don't want to get a level too early. Why is that? Won't be at steady state yet, right? So usually before the 3rd or 4th dose. And why do we care about getting a trough level for vancomycin? It's time dependent, right? We want to make sure that the trough level is not too low and make sure that we're actually getting above the MIC for the bacteria. Okay, so again, that's why we're using those trough levels instead of a peak level for those drugs there. Now, what about for the aminoglycosides? What do I do, a peak or a trough? So you do, it depends on the situation, right? For the situation we were talking about, we're giving once daily dosing, you only want to do trough levels. The reason for that is because we're giving such a huge dose that we know they're going to get therapeutic concentrations. There's no question about that. The thing we want to check, though, is to make sure that our troughs are negligible, meaning they're undetectable, to make sure they're doing what? They're clearing it, right? Because we want them to accumulate any of that stuff. So again, we're checking troughs in 2 situations here, but for different reasons. And one's for toxicity purposes, this one's going to be more for therapeutic purposes. Well, therapeutic and toxic. Okay, and then we have Lennys Lid as an alternative, right? Great MRSA coverage here. If you had something like a VRE, right? Vancomycin-resistant enterococcus, or if you had a VRSA, vancomycin-resistant Staph aureus, this is also a really good option to go with that. Good lung penetration. Dosing is really easy. You just do 600 milligrams Q12. You're done, right? You don't have to worry about renal function. Remember any interactions you saw with this? Yeah, remember you can cause serotonin toxicity if you have SSRIs. We'll get more into that next semester, but just remember that in the back of your mind. So again, as the cultures come back, and then you can scale back antibiotic therapy as needed, and then switch over to PO if possible, right? You reduce that infectious risk. If you can get rid of some of those lines, you're going to be able to switch over to PO, and it's going to be cheaper for the most part, which is also beneficial. Now, reasons why therapy may fail. What do you think? Maybe it's resistant bugs. Yeah, what else? Hmm?
Compliance issues?
Well, it shouldn't be compliance issues because if they're in the hospital, right? If they're in ICU, hopefully our nurses are doing their jobs. It's possible though. You'd be like, hey, why isn't the patient getting their drugs like they're supposed to? Oh, I forgot about it. I got a lot of patients. I'm busy. Or the patient's mean to me. I didn't want to go in the room. There's all kinds of things that happen, right? But let's assume our nurses are doing their jobs as they should, like most of them do. The grand majority of them do, right? Very well. So it could be that we have resistant pathogen. Maybe we didn't pick the correct empiric therapy, right? That could be an option there. We could have the wrong diagnosis, right? So pulmonary embolus can look similar to pneumonia sometimes if it presents with, like, say, chest pain or something. It could be cancer, right? We'll frequently have patients who will have history of an aspiration, and a lot of times people will try to treat it as an aspiration pneumonia, but frequently what it actually is what they call a chemical pneumonitis. You don't know what that means? It's basically stomach contents that are very harsh on the lungs actually cause sort of an inflammation. It's not infectious. It's just the fact it's like getting any kind of irritant chemical in your respiratory tract is going to be causing issues. Like just like if you ever inhale like chlorine gas like from a pool thing, or if you ever mix like ammonia and bleach at home. No one's ever done that. It's not great. Like you start coughing up a fit, and it's just very irritating. Kind of the same thing's happening there. So you're getting a lot more of it kind of deeper down into the lungs there. You guys are really good cleaning then. You never accidentally mix those. I had one patient at the poison center call up, and he was trying to clean out his girlfriend's cat's litter box, not his girlfriend's litter box. She used the restroom, I believe. But his girlfriend's cat's litter box, and he was trying to put bleach into it to clean it out, and all of a sudden he had all this like gas starting to form, and he was coughing up a fit. And he's like, "What in the heck's going on?" It's actually the ammonia from the cat's urine mixing with bleach, and it actually forms chloramine gas. So you gotta be very careful with your cleaning substances and what kind of animals you're using it with. Anywho, little digression. But also think about complications, right? So what are some of the secondary issues of using these really broad spectrum antibiotics? Like what do you think it does to the GI flora? It's going to kind of wipe it out, right? So, C. diff, colitis, you can see this. Lung abscess can develop here. So there's lots of different issues that can develop. Normally 7 to 8 days is pretty typical therapy. You may need to extend it out if you have something more resistant like a Pseudomonas or Acinetobacter, Burkholderia cepacia, things like that may require a little bit longer treatment times, okay? Okay, so any questions about that? All right, so let's go ahead and do 5 minutes. Is that reasonable? Let's do 10. 10 we'll come back and continue on. I'll be generous. Any questions from the first half? Yes.
For acute bronchitis, do your sites that you have to wait 5 days? When other conditions with more 7 to 10 days to rule out
So
shorter time?
So for that was when to initiate treatment. When I was mentioning on this previous slide, that's when the duration of treatment. So that's how long you're going to be treating it for, right? Versus how long you're going to wait before you start to think it's more bacterial. Kind of like how we were talking about like sinusitis, how we said like normally we wait 10 days or so before we'd really start to think it's bacterial. That's how kind of watch and wait time frame before you may give them a script to hold on to and say, hey, if it's been 6 or 7 days and you're still feeling sick, like go ahead and fill this and then take it. Some people just go ahead and fill it anyway and then just do it, so it's not great, but that's kind of the difference between those slides there. Does that make sense? So this one here is the treatment. So when you have a patient comes in, like how do you diagnose pneumonia? Like chest X-ray is like one of the biggest things, right? So again, that's one of those things where if they come in, they're complaining, they have apparently a sputum and they have fever and their white counts up and they have a chest X-ray showing infiltrates, like you kind of know it's a pneumonia, right? So in those cases there, you don't have to wait because the likelihood of it being bacterial is such that you just want to go ahead and start treating it, right? So in those cases there, you don't have any of that watch and wait period there. For bronchitis, though, because so many of the cases are viral and because using antibiotic for the majority of the cases would be inappropriate, that's why you wait 5 days or so before you'd want to go ahead and initiate therapy. But they come in and say, hey, it's been like a week and I've already been feeling miserable this whole time. And you say, okay, well, maybe it's bacterial. Let's go ahead and start treatment, right? A lot of it has to go back to the history.
My question was, why is bronchitis only 5 days, whereas the other was 7 to 10 days?
Well, sinusitis was just 10 days. I think that was the only one that you're really waiting on. It's like acute otitis media, like that one. If you see the ear, see the fluid level, all those things. Like those are things you just go ahead and just treat, right? And those are just mainly based off the guidelines, right? So they're saying that like for this particular disease state, we say, well, if it's gone on for this long, the likelihood of it being bacterial goes up, right? Yeah. So a lot of it's based off of like IDSA guidelines or whatever specific organizations you're looking at. You guys familiar with the IDSA? mentioned them before. It's the Infectious Disease Society of America. That's a really good place to go to get your guidelines. Now, if you're not sure how to treat something, where do you go to? What's your main database? Up to date. Everyone goes to up to date. They'll be using those guidelines too when they're incorporating that stuff, right? So you'll see a lot of that mentioned if you go and read like up to date articles on pneumonia, on bronchitis, whatever you want to look at, right? Anyway, so getting into anaphylaxis. What is anaphylaxis? It's an allergic reaction, which antibody is mediating it. IgE is mainly mediating this. And so, why do we care about this? Why is it important? Because it could kill somebody, right? So again, and it may strike at unknown times, right? Hopefully people who have a history of it will be able to have the appropriate measures taken, as we'll see in a little bit, but it can occur, especially with like medications. We have a lot of medications we might give to patients who can induce anaphylaxis, so it's important to have the medications available to you to treat those patients if you need to. But obviously, you know, cardiovascular collapse, airway obstruction, all these different things we're really, really concerned about for those patients. So what are we going to do for those patients? One of the big things you're going to see is hypotension is a big concern, right? So they're going to get low blood pressure. Why do they get low blood pressure? Get vasodilation. Why do they get vasodilation? The histamine is a really big component of it. There's some other ones as well, but histamine is a huge one. So we're going to see that histamine is causing vasodilation that occurs on a systemic-wide level. So we're going to get very, very hypotensive. What does the heart rate normally do to compensate for that low blood pressure? Speeds up, so it's going to try to increase contractility and heart rate. So cardiac output goes up, so they get really tachycardic. They're hypotensive. They're miserable. They're they're all itchy and their throat's swelling up. First thing we can do for them, though, easy enough to start, is going to be fluids, right? Typically, we're going to be using IV crystalloids. Anyone know when I say crystalloid, what that means? It's not like an alien race or anything, but it basically means it is a crystal, meaning salt, meaning it's normal saline, right? It's going to be sodium chloride. You say crystalloid, it means it's salt-based. Anyone ever heard of lactated ringers? Used a lot in the surgical areas. That is also going to be a crystalloid. It's basically a salt mixture in water, essentially. And so 0.9% sodium chloride is normal saline. So if you ever hear normal saline, that just means 0.9% sodium chloride. It's basically designed to have roughly similar... Oops, if that wasn't full. Okay. Anyway. That's good. Don't want to lose vodka at a time like this, right? Can't do it. Anywho, so, takes one to know one, so I'm just kidding. They say I put the fun in functional alcoholism, so. Anyway, so again, we're going to be using these IV crystalloids, so normal saline is like super common. It has roughly the same sodium content as our blood does. Anyone know what a normal sodium level is for the blood? It's a good number to know. Like 135 to 145 is considered pretty normal. Milliequivalents per liter. This has basically 154 milliequivalents per liter. So it's roughly the same, which is why it's good for us because it doesn't really shift our sodium levels around too much. So we're going to give this for the hypotension. And remember we talked about the 4-2-1 rule? I believe we talked about that when we talked about PEDS dose calculations. A little bit. Hopefully no one repressed all those memories. It'll come back to you. So remember, really good handy numbers to remember, and this is good on rotations because you look like a rock star if you know this off the bat, is that fluid boluses typically are going to be 20 mLs per kilo, right? Usually 1 to 2 liters at a time. So for adult patients, they're probably going to be hitting close to that 1 to 2 liters. Again, the thing with fluids is you can always give more, but once I put it into the system, can I get it back out? Not so easy, right? You have to diurese them or you have to give them dialysis. There's ways, but it's not going to be very quick. So we can start off with 20 mLs per kilo as a fluid bolus, and then for some really severe case, we need like 4 to 8 liters. Like you may really kind of replete these patients here because they have just such profound hypotension. And then you can do maintenance fluids afterwards as well. Remember that 4-2-1 rule we talked about? This is more for kind of a refresher than anything else, but remember it's 4 mLs per kilo for the first 10 kilograms, 2 mLs per kilo for the second 10, and then 1 ml per kilo for every subsequent one after that. So if I had a 60 kilogram patient, the first 10 gets 40 mLs per hour, the second 10 gets 20 mLs per hour, and then have an additional 40 mLs per hour left over. So you can review that stuff. All those videos are still up if you want to go back and look at that. But those would be typical kind of fluid rates you would administer. And for some patients, you may need to go above that, right? So if you ever see like start at 1.5 times maintenance or 2 times maintenance, basically just take this final number, 100 mLs per hour, and you say 1.5 times that, so 150 mLs an hour or 200 mLs an hour if you want to do 2 times maintenance. Just depends on the situation, right? So the other really important things to get on board, and again, a lot of times in a hectic, busy situation like the ER, multiple things are happening at one time because you have multiple nurses there. You may have an RT there. You may have a doc there with you. Like you may have a lot of things happening all at once. And so someone's getting the fluids ready. And then someone's also going to be getting the epinephrine ready. And this is sort of the thing that's going to be like the life-saving medication here. This is the most important thing to get on board, okay? What is epinephrine? It's catecholamine. Good. Do we naturally produce this? Yes, we do, right? It's kind of funny because some people say they have an epinephrine allergy. That makes sense? They have an allergy to their own neurotransmitters? Well, no, it's silly. However, you do have people that actually have allergies to the actual product because it actually has other things in it, like sulfites, right? So if you ever hear that, sometimes they need a preservative-free product. That's the reason why, is because they've had a previous allergy, not due to the medication, but other things that are found in that medication there. So it may sound silly, but you can kind of go back, well, maybe there's something else that could be at play here, right? Anyway, the big benefit here is going to be acting on both alpha and beta receptors here, okay? So what's that going to do for us? Well, in terms of the autonomic nervous system, this is mainly going to be focusing on the sympathetic nervous system, right? So sympathetic nervous system, what else do you call that? Fight or flight, right? So again, again, your body's going to be partying a pretty strong fight or flight response anyway, but this is going to add on top of that. So for instance, if I'm acting on beta receptors, specifically say for instance beta 2 receptors, what does that do for us? You think beta 2 receptors, think of the lung. Normally, what does that cause? Cause bronchodilation, right? Because again, what's happening to this patient's airways? They're swelling up, right? So we're trying to cause. So one of the part of it's edema. Two, the second part of it is going to actually be bronchial constriction. The epinephrine is going to help to relax all of that, right? It's going to help to relax that. Additionally, you're going to have these alpha-1 effects. By activating alpha-1 receptors, what does that cause? Vasoconstriction, right? So you're going to help with that edema. It's going to help out bring the blood pressure back up. This is the thing that's going to really help these patients out here, right? So alpha and the beta 2 effects are the big things you're focusing on here. So we're going to cause vasoconstriction, decreased vascular permeability. You're going to see that bronchial smooth muscle relaxation. So keep those two in mind, right? Because beta 2 is a smooth muscle relaxant. Alpha 1 is a smooth muscle constrictive agent there, right? So it sounds counterintuitive, but it makes sense because they're working on different tissues differently there, okay? That also help with the pruritus, it'll help with the urticaria, and the angioedema, the airway swelling that you're going to be seeing with that. So how do patients normally get this? Well, for the most part, they're either going to be giving it to themselves out in the field if they have a previous history of anaphylaxis. So if you have a peanut allergy or any kind of allergy where you may be likely to be exposed to the allergen, you always carry around your EpiPen with you. Now, are all patients really good about doing this? No. Also, EpiPens can be prohibitively expensive, right? It's kind of a big problem with that, is that it may be a cost issue. They have access to it. But basically, they will have this pen here, and it's designed. Anyone ever seen an EpiPen in use before? Oh, you have an EpiPen with you. Fantastic, right? So, yeah, if you want to pass it around, you can check it out. I would not recommend trying to use it on yourself. Otherwise, just get really hyper and just want to, all right, let's get out of here. Let's go run a mile, you know. But yeah, so it's an auto-injector, meaning that it is preloaded with a needle that has the epinephrine inside of it, and you can get two varieties of it. There's like an EpiPen, the normal dose for adults, and then there's an EpiPen Junior for kids or of a smaller weight. And basically, when they're having a reaction, they can just go ahead and take that. They can jam it into the anterolateral side of their thigh and go ahead and inject that medication very quickly. Okay, basically tell them to hold it there for at least 5 to 10 seconds or so to make sure all the medication gets in. Now, patients can be a little squeamish about doing this themselves, right? It's a little bit dramatic, so sometimes you may have to have a caregiver use it for them, whatever the case may be, right? And so that way they get the medication early and quickly, because once the airway is gone, it can be very difficult to establish that, right? Maybe difficult to get an endotracheal tube in if their airway is so swollen up to give a cricothyrotomy at that point. So that is something to consider there. Mostly IM or sub-Q is the most common route. We only do IV really if they are actively coding. When I say coding, what does that mean? It means they're in cardiac arrest, right? So if they are in an arrhythmia, VTAC, VFib, if they are in PEA, anything like that, and you'll learn about that in your ACLS section later on. If they're actively dying, then this is when we use IV epinephrine for the most part. And so there are several concentrations that are available. So for instance, if I'm giving something intramuscular versus IV, which one do you think I want to be more concentrated? Usually intramuscular, right? Because there's less space for the drug to go into. So we use a 10-fold increased concentration for the IM form than we do for the IV form. And that's really important because if you screw that up and mix it up, you can give the wrong volume, you can really hurt somebody. Or you maybe give them under a dose and then you're not helping them at all. Okay, so be very careful with that. I'm just going to kind of mention it here. I don't think I'm going to get super in depth on the details of that, but just be aware. Again, the adverse effects you can see, obviously that increase in epinephrine is going to cause a lot of anxiety, hypertension, tachycardia can happen here. They're probably going to be having some of this anyway, just due to having an anaphylactic allergy or reaction, so be aware of that. And using too much, so say for instance you get the wrong concentration, can actually lead to things like cerebrovascular hemorrhage, MI, pulmonary edema. All these bad things can happen if you use the wrong amount. Okay. In addition to that, what else are you going to be getting on board? Well, you're also going to be getting histamine blockers, and so the primary things we're focusing on is the H1 blockers, which we talked about in the ENT section, right? We talked about those. What's kind of our go-to one we like? Anyone know? Benadryl is going to be the most common one. It's the most available one we have for IV use. Certainly other ones could be used as well, like hydroxyzine. We find some hydroxyzine there, but diphenhydramine is probably going to be the most common one. And so basically by using this, you're going to find that it's also going to help to block all those histamine receptors and prevent the rash, the pruritus, the hives, all those cutaneous effects really helps out with that. So that'll be getting on board. And also think about the histamine also activating H2 receptors in the GI tract, cause a lot of acid secretion. So occasionally we'll give something like an H2 blocker along with that. And we'll talk about those more in the GI section. This is kind of a plus minus. You don't always have to do it, but certainly the H1 blocker is a definite necessary medication there. So they're getting fluids, they're going to be getting epinephrine, and they're going to be getting histamine blockers, okay? Now again, not every patient comes in full-blown anaphylaxis, so you may not have to give them epinephrine. You may not have to give them the fluids, but most patients end up getting the H1 blocker at the bare minimum, okay? Occasionally we also use bronchodilators like albuterol. We'll talk much more about this when we get into the asthma section coming up, so just kind of keep that in the back of your mind. And then we will also use corticosteroids. So patients also have to get corticosteroids when they're having an anaphylactic reaction here. And so what do you think this does for us? Yeah, it works to reduce inflammation. Now, is this a very fast-acting medication or is it pretty slow? Pretty slow. I always love it when I have nurses that are like, some nurses maybe not seasoned at really, stressful, critical situations. And they're like, where's the steroid? I need the steroid right now. I'm like, hey, I got you the epinephrine, I got you the diphenhydramine, the fluids are going, like, it's going to take a couple hours for the steroid to kick in. Give me a minute here, like, I got this, right? They get very skittish about that sort of thing. They're like, the doctor ordered it, we need to get the med right now. I'm like, it's cool, it takes a couple hours. I just it's sometimes important to kind of set their sphincter tone appropriately to say, like, it's okay, we got this. Anywho, so yes, corticosteroids is very powerful because again, you're not only worried about that acute inflammatory reaction, there's also sort of a delayed effect that can happen down the road. So by giving the corticosteroids at the same time as your epinephrine and your H1 blockers, you also prevent some of those kind of longer term sort of reactions from happening there. And you may give them, a couple of days worth of therapy. They may be on it for a week potentially. That is going to be very useful to prevent those long-standing reactions there. And so it's going to work on all aspects of it. It's going to help with the hypotension. It's going to help with the edema. It's going to help with the airway. Everything's going to be affected by this. Most frequently, we end up using methylprednisolone as an IM or an IV agent, but certainly things like hydrocortisone can also be used. Occasionally, if it's a more of a minor reaction and we're not seeing like full-blown anaphylaxis, something like an oral dose of prednisone can go a long way too. Alternatively, dexamethasone could be used here. Really, any corticosteroid is going to be beneficial. Okay. I think it's really important to educate, and kind of going back to the EpiPen, now I'm looking at it, really important to educate on how to use this. And so when you're educating patients, make sure you give them like printouts to tell them how to use it. Also, they come with trainers. I don't know if you've ever seen the trainers as well. Yeah, so basically they don't have the needle attached to it, fortunately. And you can kind of practice simulating how you would actually inject yourself, right? So because you don't want the first time you use it to be in the heat of the moment, right? You'd like to have some practice beforehand. That way patients feel a little more comfortable, right? Okay, so any questions about anaphylaxis? Kind of know the drugs you have to give versus maybe the ones you may hold off on. Again, know how to dose your fluids. Epinephrine, typically IM, sub-Q for the most part, unless they're actively dying, things like that. Okay. Anyway, so getting into, actually, does anyone know what you do if you accidentally stab yourself in the finger with an EpiPen? We calls that at the Poison Center. What do you think it would cause? Huh? A great workout? No, because it's all in the finger. What happens? The finger gets white, gets blanched because it has no blood flow to it because all the blood vessels have been constricted there, right? And cause it to be very painful. Also, it could also happen. the tissue necrosis, right? It could actually cause issues with that. So frequently what we'll do is we'll have the patients at their home, we'll have them administer either like hot or cold packs to try to dissipate the drug, to try to allow for the drug to get absorbed a little faster, and that way allow for blood flow to reestablish. Or if that doesn't work, we'll actually send them into the ER, and there's a drug we can give, it's called phentolamine. It actually blocks alpha receptors and will relax that and will allow for the blood flow to return back. That is something that's definitely of concern. That if you ever poke yourself with a finger, who do you call? Poison center, right? Because they can direct you. You want them to call you. It's like, call someone else. Like, they're free. They know what they're doing. Go for it. Anyone know the number for poison center? Everyone should know this. It's really easy. It's 1-800-222-1222. You never know when you might need it. For yourselves, for other people, when you're working. Always call the poison center. Because again, we're free, right? We're part of the health department and get good recommendations. Great. Anywho, so I didn't think I'd generate so much discussion about the poison center. My goodness. Huh?
Yeah, she has a song.
You have a whole song?
Did you guys not have those commercials down
I don't think so, no.
It was like, if you're feeling like you're poisoned and don't know what to do, call 1-800-222-1222.
Nice. Very nice. Thank you for that. You can like put the microphone closer to you so you can be immortalized. Yeah, and like up in Pittsburgh, they have like Mr. Yuck, which is like I've always thought about getting a Mr. Yuck tattoo, but I've never been bold enough to do so. But it's called Mr. Yuck. He's like the poison symbol. He's like this little circly face with a tongue sticking out. It's always used to mark poison, but anyway. All right, so getting into asthma. What is asthma? I hear a lot of sighs. So I guess I didn't hear any wheezing, so I guess no asthmatics in this group here. Anyway, so basically it's this reversible bronchoconstriction, usually brought about by an allergen, but it could be other things as well. Certainly we know we have things like exercise-induced asthma, we have things like cold weather can induce asthma, a lot of different things can do this here. But basically we're having this really marked increase in bronchial responsiveness, so it's a little bit too responsive, it's going to cause that constriction, and then what does that do to your airflow? It's going to impede it, right? So you're going to be having impaired oxygen movement, and that's obviously going to lead to things like tachypnea, dyspnea, things like that. You're going to see a lot of patients that tend to be more genetic factors. Some people are just more predisposed to it than others. Some people are going to have those reactions to those particular allergens. Now, when you're looking at the actual what's happening here, have you covered this in your medicine courses yet? Not yet, so this will be kind of your introduction to this. But basically, whenever you have the allergen coming into play here, you can see a lot of T-cell activation. Eventually, this mast cell migration and degranulation is going to happen here. So again, it's a very similar pathophysiology to what you would see with anaphylaxis, right? So again, in some cases, similar mechanisms are going to be used here. So steroids. We can see things that work similar to epinephrine being used here. All can be very useful. And basically, what you end up seeing is that you're going to find a lot of increased mucus secretion. You see bronchial smooth muscle constriction, and that's going to really impede airflow. Okay, and again, it's where you see that characteristic wheezing associated with that. Now, does every patient comes in wheezing have asthma? Not necessarily. So don't always just say, hey, let me give you some albuterol, and you'll be fine. And then they're still wheezing. It could be like a Hot Wheels car or something caught in their throat or something, right? So you never know when something like a foreign body could be in play. But anyway, it's usually going to be an IgE mediated reaction similar to anaphylaxis, right? And so this will be important for one of the drugs we'll talk about later. But basically, when they have this re-exposure to an allergen, that's where you're going to have a lot of histamine release. You're going to have a lot of leukotrienes. This is going to be an important mediator. We'll talk about getting into the medications here, and things like prostaglandins will also be released.
I have a question. So what is the mechanism? Let's say someone has asthma that's triggered by, I don't know, physical activity or cold weather or something.
Mm-hmm.
So it's not
Yeah, so that's not going to be the same sort of IgE-mediated mechanism, right? But it is going to be that same hyper-responsiveness that you're going to see there. So again, they get irritated by something, either chemo or maybe temperature receptors or something are going to be activated, and that's going to cause that reactivity there, right? And again, you're going to see that, like for instance, if it's IgE-mediated, you'd use steroids, but for someone who's say exercise-induced, that's not really an appropriate therapy because it's not the same pathophysiology. But it's a very good point you made there, right? Anyway, like I said, most asthma attacks may not be triggered by allergens. It could be due to viral respiratory infections. This is a frequent reason for people to have asthma exacerbations. They end up getting a respiratory illness. But it could be other things like distilled water, exercise. Any of these things potentially could be inducing this hyperreactivity there. Again, typically you're going to be measuring this by looking at the FEV1 and looking how that's going to be diminished for those patients. And actually what we can do is we can actually test for the hyperresponsiveness by giving an agent that actually causes smooth muscle constriction and see how they respond to it in those cases there. So for instance, there's a drug called methacholine. Sounds a lot like a neurotransmitter, doesn't it? Like acetylcholine, right? So we're also going to see muscarinic receptors are also playing a role here in terms of bronchial relaxation or constriction. And so what we can actually do is give them something that's kind of like acetylcholine causing, and if they have the hyperresponsiveness, you'll see that big drop in FEV1 and then basically induce an asthma attack almost. And then you can give them albuterol afterwards and see how they respond to that and say, yes, you do actually have asthma based on that diagnosis there. But basically what we're going to try to be doing is we're going to try to reverse a bronchospasm. So if we're having an acute issue, try to reverse a bronchospasm. We'll see some agents here that do that. We can try to remove the trigger of the antigen, and then we can also help to control the inflammation. So this is going to be one of those disease states where you have both acute management of it and then also kind of long-term chronic prevention medications. And so it's important to understand what your fast-acting medications are and what the controller medications are, right? So controller medications prevent an exacerbation. The other agents are going to be fast-acting to try to reverse an exacerbation that's already occurring, okay? And so how would you classify asthma? Again, this is a chart you'll learn about in your medicine course where they talk about, okay, well, how often is it occurring here? Is it intermittent? Is it more persistent? Is it moderate? Blah, blah, blah. We'll talk about the actual stepwise approach to management for these patients here. Again, you'll in your other classes learn more about how you actually classify the asthma here, but a lot of it's based on how often they're waking up in the middle of the night, how often they're using a beta-2 agonist, things like that are going to be factoring into how severe it is. And again, obviously the more severe, more persistent it is, the more likely you are going to require heavy use of those controller medications to try to prevent an acute exacerbation. So, as mentioned, in the long term, try to reduce that level of bronchial responsiveness, and so we can try to help to use things that reduce inflammation. And so this is where things like chronic use of inhaled corticosteroids can be really useful. So we mentioned long-term use of steroids is oftentimes good or bad. Usually bad, right? But that's more from a systemic sort of standpoint here. But certainly we looked at it in ENT, and you can use nasal steroids all the time, and it's no problem, right? For the most part, yeah, you can actually get away with pretty long-term use, and it's not a really big issue, as long as you're mindful of any kind of long-term effects, like if you were about nasal septum. But good technique will help to prevent that. However, inhaled corticosteroids also have very limited systemic bioavailability, and so they're also going to be really good for long-term control of asthma. And so then we can prevent or reverse the acute bronchospasm, and this is where we're going to find that our short-term beta-2 agonists are going to be really useful. Remember, beta-2 agonism is going to cause what in the bronchial smooth muscle? Relaxation, right? So it's going to cause dilation, it's going to cause increased diameter, better airflow going through. So to kind of lay it out in terms of the quick-acting versus long-term medications, you're going to find that in terms of quick relief, short-acting beta-2 agonists like albuterol is going to be the mainstay here. Anticholinergics can be used sparingly, and then we'll see systemic corticosteroids are good for sort of an acute exacerbation, kind of used for patients who are kind of presenting to the urgent care, to the ER. We'll talk about that. And then the long-term medications are going to include long-acting beta-2 agonists. You're going to have inhaled corticosteroids. These two are frequently given together for synergism. They have leukotriene modifiers, or mast cell stabilizers. We've already seen some mast cell stabilizers, right? Where do you see that? Yeah, back in the eye section. They also have anti-IgE antibodies, so we can actually have antibodies for our antibodies to try to bind those up. And then a very old school group of medications here called the methylxanthines, including things like the theophylline. We're not going to talk too much about that because it's a pretty old school medication we don't use too frequently anymore. However, a lot of you might actually be consuming a methylxanthine right now. Anyone know what that might be? Coffee, tea, anything with caffeine in it is actually considered to be a methylxanthine. So it actually is a bronchodilator. So caffeine itself can actually help with, and actually there used to be caffeine inhalers people would use to help with bronchial muscle relaxation. So anyway, caffeine's a drug just like anything else, right? Anywho, so cheers. So let's look at the beta 2 agonist first, because that's going to be sort of our go-to, like gold standard, like quick relief sort of medication here. Basically what these are going to do is they actually activate those beta 2 receptors, and intracellularly they will increase cyclic adenosine monophosphate, or cyclic AMP, increase levels of that, and that causes the ventral smooth muscle relaxation, right? So again, it works very rapidly. Within the first few minutes or so, you get some relaxation of that smooth muscle, and usually lasts about 4 to 6 hours or so. We have some long-acting medications we'll talk about, and these typically work more like 12, 24 hours-ish. And then big side effects you're going to see, though, is that even though they're beta 2 agonists, they're not going to be 100% specific for beta 2 receptors, and so there is some bleed over effect, right? So you can see things like effects on the heart, so that would cause what? Tachycardia, right? You can also cause some tremulousness because you have beta receptors on the skeletal muscle. You can kind of jittery. So just to divulge something about myself, I have asthma, and I remember when I was a little kid and I would get these like respiratory, viral illnesses, I would always have pretty severe asthma exacerbations, and I would have to use a big nebulizer at home full of albuterol, and so it's just a big, huge dose. You're just kind of breathing in, and afterwards you're feeling very tremulous. I was always very jittery. My heart rate was going up. I was breathing fine. I was a little tachypnic because of it too, right? So those are kind of common side effects you normally see with bigger doses of a beta 2 agonist, right? And so the short-acting ones include things like albuterol. This is far and away the most common one. You may see different brand names like ProAir or Ventolin, but they're all basically doing the same thing. And then there's also one called levoalbuterol. Do we know what the relationship there is? Yeah, it's a left-handed version of albuterol. Some people feel it has fewer side effects, but clinically, we don't really see that big of a difference there, and it's a lot more expensive. So for the most part, 99% of your patients are going to be getting albuterol. Okay, the long-acting forms are going to be formoterol and salmeterol, the two most common ones you're going to run into. Now, we actually don't use these by themselves for asthma. You might use them by themselves for COPD, which we'll talk about later, but for asthma specifically, you always want to give this in combination with a steroid. They actually did studies where they were looking at beta 2 agonists, long-term beta 2 agonists in asthmatics by themselves, and actually found it increases mortality. So just use it in combination with the steroid, as we'll look at some combos in a minute. So as I mentioned, other adverse effects: tachycardia. You can see a mild hypotension, some dizziness, some insomnia, tremors. What do you think you get hyperglycemia? Because there's beta receptors on the liver, right? If you think about a fight or flight response, what do you think blood sugar does? Goes up because you want to supply energy to the muscle so you can run away from whatever is causing your anxiety, right? So in those cases there, you cause increased blood sugar because you're activating beta receptors on the liver, right? So that's something to be watchful for in maybe your diabetic patients, right? Hypokalemia is kind of another interesting one, and actually for treating patients with hyperkalemia, we can give them albuterol sometimes to try to shuttle potassium into the cells. So if they're already hypokalemic, this can worsen that a little bit, okay? So something to note. There's actually, anyone ever heard of the drug called clenbuterol? So people like into like bodybuilding may have heard of it. So basically, it's a beta agonist, but it's thought to have some beta 3 activity, which it can induce lipolysis, and so you'll see people use it to try to burn body fat off. And what's interesting is you can actually there's recipes online. You can make it in your own kitchen if you wanted to, right? I would not recommend that. I don't know if any of you ever took organic lab and had a failed experiment. I had them all failed, so I would not trust myself to do that. I'm a pharmacist, right? But anyway, there's interesting case reports where these two bodybuilders actually present to the ER for severe hypokalemia because they made their own clenbuterol, dosed themselves, and it caused way too much shuttling of that potassium. And anyone know what a normal potassium is? It's like 3.5 to 5. These guys' level was like 1.9, 1.8, so it's severe hypokalemia due to them making their own medications there. So, otherwise healthy individuals, but just really low potassium because of the drug exposure. So again, hypokalemia is something you can see associated with beta 2 agonists. Okay. Anyway, next up you have your corticosteroids, and so these are going to be agents that we know how steroids work. These are just working very locally within the lungs to help decrease that inflammation in the long term. So patients with asthma could be just on a corticosteroid by itself, or you may use this in combination with a long-term beta agonist. You'll see a couple of those combo drugs in just a few moments here. But if you notice, when we talked about the intranasal steroids, these are all the same ones basically. These are just going to be in an inhaler form versus being in an intranasal formulation. But it's very easy to mix these up. So like I mentioned with fluticasone, Flonase versus Flovent, and it's very easy for people to screw it up. And if you just pick the first, the nurse was doing the med rec, and they type in Flo, and they pick the first thing that comes up in the chart, it may come in as Flonase or Flovent. You don't know which one is correct, right? So again, you need to make sure you're doing that med rec with the patient yourselves and make sure that's all accurate there. Now again, these are working in the long term, but they do take some time to kick in. We've already said steroids work slower than most of these other medications here, and so it can take up to full 8 weeks before you really start to see the effects here, which is why we like to combine it with a beta-2 agonist, because it actually helps with the speeding up the efficacy there, because they get the immediate effects from the long-term beta agonist, but they also will get the steroid effects to build up over time. This is also important too, because compliance is a big issue with these drugs. So if you stop taking it, what happens? Inflammation comes right back, right? So it's one of those things where they need to take it consistently, even if they're not having any asthma exacerbations. Chances are it's because of the controller medications. So just go ahead and keep them on that, and make sure they understand the importance of that, okay? Adverse effects, not too many here, but one thing to note is that there is some risk for an impaired immune system, but it's much less than you would see with, like, say, a systemic steroid. But if you had someone who's already immunocompromised, that may be a concern. There is some risk for suppressing growth, but this is really high doses you'd be seeing in these patients here in children. The one thing that is most common, though, is going to be this oral thrush. Why do you think that is? Because of local immunosuppression, right, the throat. Because imagine when you're breathing in these medications here, where are they hitting first? Hitting the mouth, the back of the throat, right? So again, it'd be nice if we could have some way to get all the medication down into the lungs, but unless you're intubated, that's not going to happen, right? So some of it's going to go into the stomach, some of it's going to go in the back of the throat, and that's just what we normally see. So by causing that local immunosuppression, they can develop this oral candidiasis. So this is why it's a really important counseling point to tell them, make sure you wash your mouth out, gargle with some water after you use one of these steroids, okay? And if they don't, they start to see all these patchy white plaques at the back of their throat. That's exactly what it is. It's going to be that thrush there. And at that point, anyone know what you could use to treat it? Nystatin's a really good option, right? Because again, that's nice because of what benefits. Not systemically absorbed, right? So they can swish and spit, or they can swish and swallow, and that's going to be effective for that. But if you can prevent it in the first place, that's always going to be beneficial, right? And so here's some of the combos you're going to run into, like formoterol and budesonide. So formoterol being the long-term beta agonist plus the steroid, or formoterol, mometasone, salmeterol, and fluticasone. Those are going to be typical combinations you're going to run into. Now again, most of these tend to be brand name drugs. They are going to be more expensive, so you just need to make note of that, right? Patients may not be able to afford that by themselves, since you may have to do them separately. About 5 minutes, I'll keep going a little bit. Next we have our leukotriene modifiers. Anyone know where we get leukotrienes from? So if you remember back to those charts we were talking about cyclooxygenase, and how that works on arachidonic acid. I'll show you a chart here in just a second. But basically, one of the pathways you saw is you had the COX pathway, which produces what? Prostaglandins, right? Prostacyclins and other things like that, for sure. There's another pathway that arachidonic acid could go down. It's called the lipoxygenase pathway. And so basically this is that mechanism. This is what they're producing as leukotrienes when they go down that alternative pathway. And leukotrienes tend to have activities on leukotriene receptors and causes smooth muscle constriction in the lungs. And so basically we have agents here that block those receptors and will alleviate that. These are going to be controller medications given in the long term. These are not quick-acting medications, and these are typically oral agents that are taking here. Most of the other ones that we've already been looking at have been inhaled drugs. These are actually going to be oral agents here. So again, what does that do for compliance? Pretty good, yeah. You can just take a pill and then that's easy enough, right? So we have things like Zafirlukast and Montelukast. I will tell you, Singulair is going to be actually the most common one you're going to run into due to some issues with CYP inhibition with Zafirlukast. We don't really use that too much anymore. Now we just use Montelukast. And basically they're blocking these LTD4 receptors. It's a leukotriene receptor, and it blocks that and will help out the mucus secretion, help with the inflammation, help with the bronchial constriction. Pretty well tolerated. I mean, these are just kind of like normal things you see listed in just any drug monograph. Honestly, these are probably the best tolerated out of any of the medications here. There's no thrush risk. There's no risk for tachycardia and hypotension, all those kind of things. They're very well tolerated. In terms of efficacy, though, they're also pretty minimal as well. These aren't going to get the same benefits as like a corticosteroid and a long-term beta agonist, but for some patients, it is enough just to help control that. And so we'll frequently give this at nighttime. It can sometimes help with those nighttime awakenings if patients are having that develop. And then we have a drug called omalizumab. You see MAB at the end of a drug name. What does that mean? We talked about those before. This is our first one. So this is called a monoclonal antibody. Anytime you see MAB at the end of a drug name, it means monoclonal antibody. It means that's an antibody that we have designed and developed to bind to something else in the body to prevent its actions, right? Just like we develop antibodies to go and bind up other things and neutralize them, we have developed ones that can do the same thing. And this is actually going to be a drug that will go and bind to IgE antibodies. So we'll go in and neutralizes IgEs, and then are they able to then cause asthma attacks? they cannot, right? Because they're all bound up and they're neutralized essentially. And so what do you think this does to cost? We're going to engineer our own antibody, engineering a protein. It's really expensive, right? So these are going to be for refractory patients. They've tried everything else, nothing's really working for them. Then they'll go ahead and go on this. Also, if it's an antibody, it means it's a protein. It can't be taken orally because your stomach acids will just destroy it, right? Proteases will destroy it. So this has to be an infusion or an IV drug we're actually giving here. One of the big things I'll make note of with the monoclonal antibodies is that they all carry a risk for anaphylaxis. Anytime you're injecting a foreign protein into a patient, you run the risk of having anaphylaxis, okay? Now, some of it has to do with the type of proteins you're involving here. If it's more human protein, that's less likely. But sometimes we actually have animal protein mixed in there. So sometimes you'll have murine protein mixed in. Anyone know what murine means? What animal that comes from? From a mouse, yeah, actually. So have like mouse proteins may be involved. So it just depends on the type of antibody you're using there. Now, anyone know what the side effect is if you're using those murine proteins? They really want cheese afterwards. It's really strange. I'm just kidding. That's not true. But anyway, so that is the biggest risk, because one, it's going to be expensive. The anaphylaxis risk is going to be much higher than any of the other medications we talked about. And also they have to come in and get a sub-Q injection every 2 to 4 weeks or so, because you do have to be monitored for a short time after to make sure that you don't have any kind of negative reactions there, okay? And this would be a drug that you'd want to have anaphylaxis meds available to you just on the off chance they have a reaction. So you want to have epi available, you want to have your Benadryl, you want to have your steroids available to you, right? Because again, you can see urticaria, anaphylaxis, and more common things would be bruising, some injection site reactions there, right? Okay, so I'm going to cut it off there. Any questions before I let you go? Let me check. I'll go over the quiz and see if there's any like high misses or anything. I don't think so. It looked like it was pretty fair. Okay, I get really sick every time I get the flu shot. Why is that? Why is that? Why do you think you get sick every time you get the flu shot? So we won't get too in-depth on vaccinations. We unfortunately don't have time to cover that in depth. But one of the things you'll see is if you ever look at the type of flu shot you get, very frequently it's called a live attenuated influenza virus. What do you think a live attenuated means? It's still alive, but it's been made weakened, right? So ideally it's not going to cause the flu in you because it's been weakened, but it's still alive. Why do we inject live virus? You get a better response to it. You get a better durable response. Well, that response is inflammation, right? You're developing an immune response to that. So some people will feel like, oh, I always get the flu after a flu shot. That's just your body's natural reaction to that, to develop the immunity. So that way, that when the real flu comes around, the strong one, you hopefully will not get that. Now, anyone know how many strains of flu actually are prevented with the flu shot? The standard now is 4. So if you ever see quadrivalent, that means it has 4 viruses that protecting it. It's 2A and 2B. Some forms are trivalent. They'll obviously will lose one of the B strains there. Now that is how effective it's going to be for the season is how good they are at guessing what flu strains are going to be most present. So just because you get the flu vaccine, does that mean you can't get the flu? No, it just means you got one of the ones that that was not predicted. Are they bad at prediction some years? Yes. Some years are way worse than others. It just depends on, and again, I have no idea how they do their prediction models. A lot of epidemiologists will probably do a whole lot of things on that, but that's the reason why. Yes, ma'am.
So you give live attenuated strains to pregnant patients?
Yeah, that is still okay, right? So and they can still have, that's still recommended by ACOG, and so the American College of Gynecology, they still recommend giving the flu shot, Tdap, all that good stuff to the pregnant patients.
Live attenuated.
Yeah.
I didn't know there was
Will they ever modify what strains are in the shot based on the data coming out of what strains?
No, once you have it for the year, that's kind of what you got. Yeah. Yes, ma'am.
You are symptomatic because of the flu shot? Are you contagious?
You are not contagious, at least as far as I know. I don't think so. But and again, how would you manage that? They had like fever, myalgias. I probably wouldn't give them Tamiflu for that, because again, then you're trying to block the virus, and then like you don't get the immune reaction to it. Tylenol, fluids, they'll be fine, right? So it should be relatively short-lived.
So I've heard that like the longer you wait, the better, because there's only like a certain duration that you get the immunity. Is that true?
So yeah, so some people were postulating that by getting earlier flu shots, that the durability of it, so to speak, would be lessened, such that if you got it like in July or August or something, that you wouldn't have protection by the time you got to the later cold months. So like for instance, like now at Nemours we're doing the flu blitz where everyone's getting their vaccinations in October, so that way you should be covered throughout the majority of the months. Because sometimes we're starting to see later and later presentations. It depends on the season, but sometimes you'll see people still flu positive in March, April, May in some cases, and so in those cases there we stay protected for a little bit longer time. Because it's very rare you get the flu in August, but it's certainly more likely as you get later and later towards the cold months. Little impromptu talk on the flu. How do we get hypersensitivity from antihistamines, and how would you treat it? So again, it may not be related to the antihistamine itself. It could be related to some of the adjuvant products that are in there, right? So preservatives or coloring agents or things like that. Like Benadryl usually comes as a pink liquid, if it's a liquid. Maybe they have a reaction to red dye, for instance. And so in some cases, you could use a different antihistamine. Sometimes they may need a steroid. It would just depend on the reaction, how severe it was, right? And then if you're already hypertensive and you have anaphylaxis, can you still take an EpiPen? What is another alternative? Yes, you will still need an EpiPen because, again, I would rather the patient be hypertensive and have their airway open versus the alternative, right? So that may not be the case for every single really hypertensive patient, but as an alternative, maybe if it's not so severe, you can always just intubate the patient, right? You can get the airway established and then manage the hypotension with other agents like fluid, steroids. So I've not run into that situation too commonly. Because hypotension is if they're having that severe of a reaction, hypotension is going to be pretty commonly seen with that. So, any other questions?
But I thought you're hypotensive when you have anaphylaxis.
Exactly. Yeah. But not every reaction is going to be full on anaphylaxis. You have an anaphylactoid reaction. It's going to be somewhere in the medium there. So not every patient has to get epi. Some patients may just need Benadryl and a steroid, right? Just depends. Any other questions? Nothing else. I will see you guys next week.